Um, my name's Michael Fine. I'm president and board chair of Primary Care for All Americans, and I've never been prouder of being able to say that because of the work that you'll hear about tonight and the work that's going on around the country. It's really amazing and spectacular. On behalf of the board, I want to extend a warm welcome to all of you to tonight's Teach and Learn in Zoom. Thank you so much for joining us tonight. We've now got over 1,200 people in 40 states, in the District of Columbia, and 350 zip codes or more. And we keep seeing the tremendous momentum we're building together to provide primary care to everyone in every American neighborhood and community. These are interesting times for sure. So thank you in the spite of them, in the midst of them, for your dedication and commitment to doing this as one people, as one nation. So we build something and provide something that everybody needs in every neighborhood and community. About 2 months ago, we released the Primary Care for All Americans local playbook, which provides amazing and valuable information, strategies, resources, and ideas aimed at expanding access to primary care at the local level, community by community, neighborhood by neighborhood. Tonight, we'll be discussing how to use that playbook to form work groups inside your community. We'll hear from people who are organizing local work groups in their own communities who can help you understand how to do it. It's my great pleasure to introduce our moderator for this evening, Fatima Khan, and to extend my sincere thanks to all of the presenters for tonight's event. I'd also like to thank the Primary Care for All American Zoom Committee, as well as John Wright, Brian Kaiser, Patty Armstrong, Alan Roth, and Liv Varity for organizing this amazing event. Take it away, Fatima.
Hi, everyone. I'm Fatima Khan, a family medicine resident at Jamaica Hospital Medical Center in Jamaica, Queens, New York. I want to start by thanking you all for being here tonight. By joining, you're helping us build a movement, one that's focused on providing healthcare for people in every neighborhood, in every community. Primary care for all Americans. Please take a moment to share where you're joining us from in the chat, so we can see who's here as we work together to build this movement. And as we do, let's refrain from using professional titles. This space is about focusing on the importance of being here together, engaged in this work, and valuing the ideas and commitments that will ultimately drive this movement forward. Now, it's my great pleasure to introduce the co-chairs of the Primary Care for All Americans Local Playbook Workgroup, Sarah Pasur and Matthew Libby. Sarah Pasur is a board-certified and clinically active family medicine physician, an accomplished primary care champion and leader. She is an experienced primary care innovator in military medicine, academic medicine, private practice, street medicine, and employer-sponsored delivery models. She currently serves as head of primary care advancement at Elation Health, a primary care-focused EHR company. Matthew Libby is a family physician and healthcare leader with experience innovating in community health and in the tech startup space. He is currently serving as the Chief Medical Officer at a Healthcare for the Homeless organization on Cape Cod. Matt is also a board member and treasurer of the Massachusetts Academy of Family Physicians and an instructor in family medicine and community health at the University of Massachusetts Chan Medical School. Tonight, we are here to both teach and learn from each other. We encourage you to contribute by submitting your questions in the chat throughout the session. Please stay with us at the end of the session, where we will have time for Q&A and discussion. We will be exploring how you can help bring primary care to everyone in your own neighborhood and community. Now, without much further ado, Sarah and Matt.
Thank you very much. I'm going to put up some slides, and Sarah and I will take just a few minutes to go through them so we can give most of the time to our panelists who have some experience actually doing this work. But for those of you who are familiar, hopefully there won't be much repetition here. For those of you who aren't, I just want to give a little intro into what this work is really about. So um, it's building a movement for primary care for all Americans, as you heard in the intro. And the local playbook that was referenced is available on our website. We can put the link in the chat. And that's our playbook on how to get started doing this work in your communities. Um, some inspirational words from Michael to start us off at the top. Always good for that. So we're trying to seize this moment to create a movement for primary care for all, a movement that will not only transform our healthcare system, but also heal the divisions that threaten to tear us apart. Together, we can ensure that every American has access to the care they need and deserve, building a stronger, healthier, more united nation. I think it's probably not news to anyone on this call that the U.S. healthcare system and health in general in the United States is in a crisis. Sometimes people talk about an impending crisis. It's not impending, it's evolving, and it's here and has been here for a while. It's not a new thing. Just a couple of graphs to show, if you don't already know these statistics, we spend far more on healthcare in the US than most other high-tech wealthy countries, and we have worse outcomes to show for it. Um, and the reason that one of the main reasons that that is the case is because the healthcare crisis in the US is a primary care crisis. We spend a far smaller piece of our healthcare pie on primary care than other wealthy nations do. And part of what drives that is we have the largest disparity between primary care and specialist physician compensation. Um, and the outcomes of that is that 30% of adults and 14% of children in the US lack a usual source of care, which leads to higher costs, more advanced, complicated conditions downstream, fragmented patient experiences. People are unhappy with the healthcare system they're interfacing with in a lot of instances now, unless they're fortunate enough to have access to high quality primary care. And it results in worse health outcomes and increased inequities. Primary care is proven to be effective in reducing cost and improving health outcomes overall. So, primary care for all Americans' mission and vision is to build a healthcare system that is for people, not for profit, that starts by providing advanced primary care to every American in every neighborhood and community. And uh, every American with a family doctor or family practitioner, and every neighborhood and community with great primary care practice. By including everybody, we're looking to improve public health, lower costs, help strengthen our country. So we need to make primary care foundational of our healthcare system in order to fix the healthcare system crisis. The local playbook is a large document, very resource-rich document that has resources to do that. Has you'll see when you open it up and look at it, but it outlines the steps to take for forming a local work group and for identifying what the situation is in your community. And how to start solving it together with some ideas on how to get started. So some key features that you'll see in it: strategies for assessment, intervention, methods for engaging people, either stakeholders in the community, policymakers, and then tools for building a coalition. And from here, I'll let Sarah take the next few slides.
Thanks, Matt. So most of us have probably never done community organizing, and you might not know where to start. So we've got you covered. The local playbook can give you clear recommendations for ways to get your movement started and growing into meaningful, lasting impact for your community. Members of a local work group should reflect the community that it serves, and this should not just include healthcare professionals. It should also include those who receive care locally, as well as those who lack primary care locally. Assessing your local healthcare needs will help you better communicate your needs to partners, policymakers, and community members in a compelling way. And coalitions unite people with common goals. The playbook details 4 key steps for building a coalition and engaging strategic partners focused on a unified vision and goals. A clear action plan with priorities built on consensus, complete with an accountability structure, will help you move from planning to tangible results. And then collaborating with local government and agencies and your state work groups to advocate for necessary interventions to support primary care will be necessary to align policy with your goals. Matt, are you on slide 9?
Yeah. Are you
Great.
seeing it?
Thanks. So let's talk about expanding access to advanced primary care. And this starts with engaging local leaders and organizations to raise awareness about the needs in your community, which you will be equipped to tell them. You might find it difficult to influence the insurance-based primary care market in your community, but the playbook will describe for you some ways to solve your primary care access problems through community-owned initiatives that operate outside of the legacy healthcare system structure. One of the biggest challenges we'll face in this initiative is availability of well-trained primary care interprofessional teams. And the playbook will give you some ideas to help you start addressing this. And as we work together, we look forward to sharing our successes and best practices, proving that it can be done. And then addressing the gaps in primary care for those who need it the most and also have it the least will not be done without collaborating with your local EMS, housing programs, and other social services, which will be a crucial factor in making meaningful impact on costs and outcomes of care in your community. Next slide, please.
Yep.
We want to point out that there is a really nice section in the playbook that gives a framework for how to think about how you measure both the baseline and success of your work as you make progress. This will be so important to your group's ongoing success, if for no other reason than to fortify you and reassure you that you are making a difference and your work matters to your community. Next slide. You, yes, you, can find one other person and start a group. That's all it takes. We're going to hear from our panelists in a moment who've done exactly that. We also encourage all of you to participate in the process of advocacy. Primary care is a bipartisan issue, but leaders and lawmakers need to hear from their constituents that it matters to you, and they need your help knowing what needs to be done. So be sure to stay connected to this group and share your success and reach out for help or resources and leverage every resource you can find to empower your success. Next slide. If you haven't already, please join our movement at primarycareforallamericans.org. Follow us on social media for news, events, and other announcements. We recently made 2 Primary Care for All Americans community groups on LinkedIn where anyone interested can join, ask questions, seek like minds, share best practices, and find community. And those are local at Primary Care for All Americans and state. And if you're in a work group and want to share something or have a question, you can email us at the email addresses you see there. And I just encourage each of you to pick at least one thing and get started today.
Great. I'm going to stop sharing now and introduce our panelists for one moment here. Okay. So we have 3 panelists tonight who I'm excited to introduce, and they'll share their personal experiences in forming some local work groups. We're thrilled to hear from Pam Kavanaugh, Gabrielle Yaru, and Christy Romero. Each of them has a unique perspective, and their stories will inspire us as we continue our work. Pam Kavanaugh retired 3 years ago after working 38 years at the New Bedford Community Health Center, a federally qualified health center. Her last administrative role at the health center was Chief Quality and Compliance Officer, and Pam came out of retirement in August of this past year to become the project lead for the Primary Care for All Americans New Bedford work group. Gabrielle Yaru is a family medicine attending physician at Jamaica Hospital Medical Center in Jamaica, Queens, New York, and she serves as the pioneering project lead for the Primary Care for All Americans Queens work group. And Christy Romero is a recent graduate of Providence College. She's bilingual community health worker at Family Service of Rhode Island and is based at Jenks Park Pediatrics and serves as the project lead for Primary Care for All Americans Central Falls work group. So welcome, all three of you. I'm going to pass it back to Sarah to ask a starter question.
Yeah. Welcome all of you. It's so great to have you here, and thank you for being willing to share your stories with us. Pam, welcome. We'll start with you, and I wanted you to tell us a little bit about your community first, and then I'd love to hear you share about how you got your group started from scratch, which I think is the biggest hump to get over for anyone doing this. And when you did get started, what did you do first? Who did you invite to work with you? How did you go about it? What has your progress been like?
Thank you, Sarah. I'm Pam Cavanaugh. I live in the city of New Bedford, Massachusetts. New Bedford is a community of about 102,000 residents. It's a very diverse community made up of a large portion of Spanish, Portuguese, and Cape Verdean language needs. Primary care in the city of Massachusetts is delivered by basically 3 primary care organizations. Of those 3, only one of them is located in the city limits of New Bedford. So that means a number of the New Bedford residents, in order to receive primary care, need to travel a distance to one of the other locations outside of the city limits itself. So in August, I was asked to come out of retirement and be the project lead for a new work group that was going to be starting in New Bedford. That work group was established in early September. Now, back in September, I did not have a local playbook to kind of guide me along the way. So I was kind of shooting from the hip a little bit. But because I worked in the community health center for 38 years and I live in the city of New Bedford, I knew a large number of people and they knew me. So it was a matter of trust, I think, in the very beginning to get this core group together. I started with a contact list of approximately 10 individuals who I did know, and I had email addresses for those individuals. So what I did was we came up with an invitation letter, a very simple invitation letter, basically stating we weren't looking for anything from them other than a little bit of time and to participate in making the community of New Bedford better for primary care. So we had our first work group, and of that 10, I believe we had 6 people that showed up for that work group. And I don't know if it's because they knew me and they had worked with me in the past that made it a little bit easier to get over that hump. But that group has grown quite a bit since September. And how did it grow? Every single meeting we had, and we meet bi-monthly, every other week. And what I would say, of all the people that are in attendance, who's not here? Who should be at the table with us? Who should be part of this engagement? Please send me their names and contact information, and I'll take it from there. So that group, every time we meet, has grown. I don't think I've had a meeting yet where I have not gotten additional names added to my contact list. I'm happy to say that my contact list is now up to 47 individuals. And we've been averaging about 22 individuals at our bi-monthly meetings. So I think that's pretty good. And the group is an extremely engaging group. I'm going to tell you, last meeting we had last week, one of the members of the group, who happens to be a clinician, says, I'm really happy to be at this group. I found it very therapeutic. And I think that they get a sense of they're not alone in this issue of providing primary care to their patients. So From that invitation letter, this group has begun to evolve, and now we've started to collect data. Data is our driver. So I came up with, along with Michael, a list of about 25 questions to try to get an assessment of the community. How many providers do we have at each of the practices? How many are MDs, DOs? How many are advanced practice practitioners? And from there, we started looking at how many patients do they have in their patient panels? How many patients can get an appointment within a short period of time? What we're finding has been very, very interesting. Not enough providers, too many patients, too long of a wait list. One of the practices can't see patients for at least a year. So that's very telling. Okay, so we're continuing to gather this information, put it in a spreadsheet, and from that information, we're going to be developing a primary care report. We've started to work on that, but it's still in a very draft format, which will share some of the demographic information of the community in New Bedford, as well as what it is that the clinicians in the practices are facing on a daily basis.
That's such important work, Pam. And the assessment of the community is one of the steps in the work group that we outline some suggestions of how to do that. And I know you have some resources that you've developed that we want to put links up to on the website so people can get into that. I wanted to also highlight, Gabrielle, the community you've started a work group in is a little bit different, and you've developed a little bit different initiative in that community. Do you want to speak to what you're working on there?
Yes. So I am in Queens, New York, which is a unique community of around 2.3 million persons with a large immigrant population of roughly 47.6% of the county's residents being foreign born. So we have many people from across the globe, including a Latin American, Asian, African, European populations, and roughly around 138 languages are spoken throughout the borough. So a pretty unique population, but a really inspiring place to work. So we all know that the physician shortage and the urge for need for better primary care access. New York State is estimated to need around 1,200 PCPs by 2030. So how do we do this? In addition to legislative reform to increase funding within primary care, we also have to find ways to get more students into primary care and basically working with what we have. So we recently acquired a grant through the New York Health Foundation to assist with this effort. One arm is the pipeline program, as mentioned before. So the name of the program is Next Gen Health Ambassadors, and it's designed to empower future healthcare leaders. So it starts with high school students, 16 and up, and we would partner with hospitals. Currently, we have 2 hospitals that we're partnering with for their family medicine residency programs to partner with the students. I've met with the volunteer offices of both hospitals, and working with them, I've been able to figure out what schools that they are already involved with and who are they already in contact with, aligning them with the residency program to have those students who are interested in healthcare careers rotate with the family medicine residents. They would be required to present a quarterly presentation aligning themselves with community-based organizations who would have health fairs or maybe like a civic association or anything like that, where they would then present what they've learned during that time pertaining to the vitals of that area. So let's say, for example, if hypertension is prevalent in this area and they've learned about this during this time, they will then present at these different fairs or awareness events to speak on what they've learned. So how does this help? This will help because it'll allow the students to see what the health disparities are within their community. Hopefully, they would say that they would love to stay within their community based on seeing what the needs are and come back and decide to be a physician there. That's just the students. But what about the residents? A lot of the residents come into the community and plan to go back home for many reasons. But hopefully, we'd be able to create basically a sense of ownership to the community that they served in. Having aligned with the students and worked with them and then presented at community-based organizations, doing a lot of on-the-ground work, they'd be able to say, you know, I see the need. I've been able to intervene in this way. It might be necessary for me to stay in this community and continue my efforts here. And so that way, we'd hopefully capture that resident and have them stay within the community.
I love this so much, Gabrielle. I love that you're tackling both the short ramp and the long ramp, right? Like you're solving the problem for long term and also near term. And these are such creative and wonderful ways to help address that workforce shortage crisis in your community. So thank you so much for sharing about that. We're going to pivot now to our final panelist, which is Christy. Welcome. And you're new to this, and so we want to hear what this has been like for you, freshly new in this role. Tell us about your community and what you're doing and what your role is in your work group.
Yeah, thank you. So Central Falls is a very resilient community. For many of the residents, it's a new beginning, and I've seen the residents open their arms to each other and newcomers in ways that I haven't seen before. And I think the residents are really eager to learn and grow. It's a relatively small city, as in it's only 1 square mile, but it homes around 22,000 people, and 5,000 of them, plus an additional 5,000 who are undocumented. So for a total of 27,000. The 65% of the city is Hispanic or Latino. And some of the languages spoken are, Spanish, Portuguese, Cape Verde Creole, other forms of Creole, and English. So around 10,000 of these individuals do not have primary care. And that is a very large number for such a city. So in my new role, I inherited this group of around 6 members outside of admin. And I've been doing this for around, I want to say 3 weeks. So it's very new. And I inherited this from Margaret, who has been a great instructor, and Pam has also been teaching me the ropes, and so has Michael. They've all been really great. And I don't think I would be able to do some of this work without their education in these first couple weeks. But the really crucial part for me right now is to reestablish relationships with the people who are already in our group. So I've taken the time to sort of reach out to people who haven't been participating in our meetings and see what's the barrier there. Is it the time? Can we fix that? I also just reached out because I want to know about them. Where do they work? What do they care about? Do they have children? What do they do for fun? But also, what do they think the community needs, right? Because I want to learn from them as I am also learning about the community that I work in. I think I'm in a great role as a community health worker because every day I see the need in the city, and every day I work towards alleviating that need. And it's great to collaborate with people who have a similar vision. And we all know that primary care is such a necessary thing to achieve healthy lives. So really, it's about reestablishing that drive that I know the members already have and making sure getting people to the meetings. And then it's about recruiting, right? So I'm actively trying to recruit. I think the best way to approach this is to go to places that serve people, right? So, a great one is we have something called Progreso Latino. So, I go out there and we can go to the library. I'm working on that right now. I'm also trying to get in contact with churches, faith leaders. So that's my approach to recruiting people in our community. And it's also about meeting people where they're at. So Michael and I have been working towards doing our meetings in a dual language model. So we've been working in Spanish and English. I am bilingual. I speak Spanish for most of the day. So it's great to see the members being able to participate in ways that are fruitful for them and they feel like they're heard. So yeah, that's a little bit about what I've been able to do so far in our work group. And we have much to learn. It's great to see Pam leading the way and Gabrielle also learning from her sort of pathway programs.
Well done, Christy, and all of our panelists. You guys really are blazing a trail here. You're doing something that no one else is doing anywhere in the country, and you're an inspiration to all of us. Thank you so much for the work that you're doing and for sharing that with us. So now I think we are ready to take some questions from the audience. If anyone would like to chime in, either turn off your mute or speak up in the chat. We'd love to hear from you, and we have just a few minutes to take a few questions.
So I have a quick question, if I can jump in. Pam, you mentioned not having the playbook when you first started. How, for the three of you, has the playbook really changed your approach or like helped guide you moving forward?
Well, for me, not having the playbook and seeing the playbook now, if I had had the playbook back in September, I think it would have been a little bit easier. But, you know, I had to work with what I had. And that was just basically knowing the community and knowing some of the players. But the playbook is a great, great guide and resource for how to do this grassroots.
I see Gabrielle nodding.
Yeah,
You can go ahead and take it away, Christy. I was just agreeing because I also didn't have the playbook initially. But what helps is when talking to people who want to do the same work and pointing them to a playbook. So that's what I was actually agreeing to.
So I have had the playbook in my new role. I think that it's a great resource. It is very extensive. It goes into detail about how to establish these things. And it's a great reference as I have questions. And like sometimes I'm like, what is the main goal here again? And then I revisit that. And then it's just all laid out for you. So I think it's a great resource in addition to all of the great mentorship that I already have.
Well, we appreciate those testimonials, don't we, Matt?
Very much, yeah. And it's and thanks to all the people who worked on writing it, you know, you'll see the authors are some very experienced, accomplished people. And so we
Many,
really,
many of whom are with us tonight.
yes, a few of them are. So a lot of really great minds went into putting this together, and I'm excited to hear how it's of use to you in guiding the process.
We have a question for you, Christy. What is your day job? Are you in healthcare?
So I am a community health worker at Jenks Park Pediatrics. So it's a pediatric clinic, and I work in what we call La Casita. And essentially what I do is address immediate needs and do screenings such as, social determinants of health. We know these things impact our families' lives, and we need to address them so that they can have a better outcome with treatments and other things like that. So it's a great location that I'm at. I work with a lot of the patients that are at the clinic, but we're also open to all of the community. And I see people every day. I help apply for health insurance. I get them food. I get them clothes. I get them anything and everything that I can.
It is such amazing work. And I saw Margaret's comment in the chat that speaks to that. The playbook is a playbook, not a cookbook. I think maybe Larry Bauer said that, or it came from one of our authors, but um, The idea is it's to help guide you, but you're the expert in your community, and you are really embedded in the community doing that work day to day, like you said. So, um, you know that piece well, and we're just really here to help give you a menu of suggestions of things that might be helpful that have helped in some communities, and some of them may be relevant and work in your community, some of them may not, but you're going to help figure that out. And you'll pull together the people who you need to get those things done.
A lot of what I'm hearing from this team is that Pam and Christy, you particularly said it, it's about building trust, right? Because you have to build that community around you, and then you have to nudge and remind people and draw people back in. And I don't know anyone who nudges better than Michael Fine. He has taught all of us very well. And Michael, I can just see the pride in these presenters and the work that's been done here. So I want to open things over to you to just share a little bit about what's going on. But you have to come off mute first, otherwise we won't hear.
Got that done. Thanks, Patty. Thanks to Matt and Sarah and Pam and Christy and Gabrielle and everybody for being with us tonight. As Patty said, this work is amazing. I was trained as a community organizer once upon a time. And to see all you guys doing it and being in your communities and connecting to people and bringing people together, man, that's what it's all about. There was a question in the chat about what Christy's day job is. And the thing I want to point out is that everybody here has a day job. Everybody here is a volunteer doing this 5 hours a week, sort of finding the time to make it happen so that we can build this movement together. So thanks to all of you tonight for your wisdom in telling us how to start a local work group, work that's really putting your communities on the road to providing primary care to everyone. But for the rest of us, what they've done, you can do too. Remember the power of two, as Sarah said. Get together with one other person and get started. We'll help. So hello, Marfa, Texas. Hello, East Harris County, Texas. Hello, Belfast, Maine. Hello, Woonsocket and Newport, Rhode Island. Hello, Ashtabula, Ohio. Hello, Bellingham, Washington. Hello, Richmond, Virginia. Hello, Phoenix, Arizona. It's time to stop admiring the problem and time to get started fixing it. We really are all in this together, and the rest of us are here to help. So get started. And before long, we'll feature your community and your work on one of these Zooms as you teach us what you've learned, and then we learn together how to get this done. If, by the way, you're in Rhode Island or if you're in Massachusetts in the next few days, please contact your state legislators and tell them about the importance of primary care in both state houses. There are different processes going, and everybody needs to hear from you so we can move this along at the state level. This is the way we get going community by community, and this is the way we put all hands on deck. Fatima.
In 2 weeks, we'll be meeting again. We encourage everyone to invite someone new to get involved in this impactful movement. Let's continue growing and making a difference together. Mark your calendars for our next Zoom meeting on March 11th, where we'll hear from Alana Krolikowski about how maternal health is an integral part of primary care. We look forward to seeing you there. Register on our website, primarycareforallamericans.org, where you can also check out our local and state playbook, volunteer and donate to support our cause. Now, I'd like to introduce one of our board members, Alan Roth, who will share why donating to primary care for all Americans is so important.
Thank you, Fatima. I'd like to appeal to everyone for two things. Everyone on the call today who is doing such amazing work is speaking to dozens of people every day. And when you speak to those dozens of people, we need you to sign them up as volunteers. Every member that's added to our Our list will help us get more grants. I think we had some good success in New York because we had a reasonably good membership. So as you meet people, as you speak to them, sign them up. We need people to sign up, and that will help us get to our goal. Membership is important to us. And to keep us going, unfortunately, we do need money. I've given a monthly pledge. Many people have given a monthly pledge, and I really appeal to all of you. We need to hire an executive director. We can't do this on our own. We need full-time help. So give what you can, $5 a month, $10 a month, 25, 100, 250, whatever you could afford to give. But if we could get pledges on a monthly basis, we could really plan our budget and continue the great work we do. So thank you so much, Fatima.
Thank you. Thank you for joining us tonight. We appreciate every single one of you helping to spread this movement across our nation in order to get the change you deserve. Please take a minute to complete our survey. The link is in the chat. We want to hear from you. If you would like to talk with members of the leadership team, stay on the call, and board members from Primary Care for All Americans will stay on to hear your feedback to help us grow as a community. Thank you, everyone. See you on March 11th.
Thank you so much, Fatima. The work that's going on here is absolutely incredible. And we do encourage you to stay on for just a few more minutes as we will answer some additional questions. Jonathan Bushman, where are you joining us from?
From a loud bathroom with kids in Oklahoma.
Welcome from
Um,
Oklahoma.
yeah, rural Oklahoma.
Very nice. Yeah, well, as Matt Libby said, we can get you connected in. Matt, do you want to share a little bit about sort of what we do on a state level as well? Because I know you're also on that state workbook team.
Yeah. And at state level, there are often other organizations advocating for similar things too. And so it's a lot of trying to find people who are doing that work and ally with them. There's other states that have active work groups going that maybe Michael or others on the call are part of and could speak to best. But the first person who came to my mind in Massachusetts is Wayne Altman, who does a lot of advocacy for primary care payment reform at the state level.
Absolutely.
Reaching out to Jonathan as soon as the call is done, so we can have a conversation about how we can help.
Absolutely. And I think that's what's so important about these calls, and especially about what was talked about today, is really whether it's Pam, Gabrielle, or Christy, or any of the other team members, we are here to help and support this journey moving forward. And so if people have questions, drop them in the chat. We'd love to cover a little more information from you, for you, of, what is it like to get started? What kind of cadence do you maybe have when reaching out to people? How often is too often? How far apart can you message people? What the art of the nudge, I guess we could call it. Do any of you guys that presented today have any of those insights that you could offer?
Say just go for it. Email as many people as you can and just see who bites. I mean, that's what I basically did for the local politician's office and trying to get them on board with providing things for the students that would be involved, and just seeing who's gonna bite, making sure that they understand that primary care is an issue, and just shooting your shot.
I love that. Pam, what about you? What did you find to be a good cadence for being in touch with people?
Well, I was afraid in the beginning to nudge too much, but our meetings are on Thursdays, so I send out an email to the group on Monday, and then I do a friendly reminder on Wednesdays, and that's pretty much it. Where I've had the biggest nudges is with the primary care the 3 primary care organizations in getting data. And with every email I say, I know this is difficult and I know I'm nudging a lot, but this will really help us. And bit by bit, we've been getting the data. But that's been the biggest nudge, I think, is working on collecting the data.
Pat Tokars asked about, Pat, do you want to come off mute and ask your question?
Well, I just had some practical questions. I've found there's 2 groups of people, some who are able to meet during normal hours, work hours during the day, and some that can only do it in evenings, others who choose to have meetings in evenings. What has worked out in your 3 groups in terms of the time of day and the frequency? And do you try to do like here and do a 30-minute condensed meeting, or do you go for an hour and a half? What are the practical, what works out best in your local communities?
So Christy, you just made a change. Did you want to talk about that?
I did want to talk about that. This is a serious question because I've wrestled with this within the last week or so. I have moved forward with doing a poll to see, what are the availabilities of everyone. That resulted in a lot of different answers. So, everyone is so busy and everyone has a schedule. And as I've gotten to learn about people individually, I am trying to accommodate as best as we can. We have moved forward with doing a 30-minute session at 8 in the morning, right before work. Right? Because this is the time frame where some of the people who really want to be active, who just haven't been able to because they're working at night or work is interfering, they're able to participate. I'm hoping that this new change will be fruitful for our group. I am open to readjusting as needed, but I think that's the key, right? You have to be open to changing things if they don't work.
Are these Zoom meetings?
Yes. So we do a 30-minute Zoom meeting bi-weekly. The commitment is, which Michael has taught me, that we want to make things as simple as possible for folks. So when we keep it short, people are more inclined to join, and we have an agenda prepared for that session so that we get to target everything that we want to talk about within that time frame. So, in regards to just how much to reach out to people, I've realized that it's best to reach out to people individually sometimes. It's great to send those mass emails, but when you reach out to an individual, you're like, hey, this is a conversation me and you are having. Can you help me out with this? And they're more likely to say yes.
I think,
So it's
Christy,
great.
that speaks so much to what Pam was talking about. Pam, you've done an amazing job of increasing your participation, right? And I think one of the things that you said that stood out is it's therapeutic for your participants. So you've done something there that's really created community.
Well, I'll start with the schedule time. We started out with a 3:30 slot time to meet on a Thursday. And it wasn't working for a lot of the clinicians because they were wrapped up in seeing patients. So we didn't want to draw them away from that important work. So they suggested, let's try 7:30 in the morning. And it has worked. So I know Michael tries to keep the meetings to 30 minutes, but this one particular clinician last week who said this was very therapeutic, he says, I know we're trying to keep it shorter, but he says, I've got some questions. And he says, I really enjoy coming because this is very therapeutic for me. So, the meetings generally go 30, 45 minutes. But when you're dealing with 20-something people, it's kind of hard to keep it to 30 minutes all the time. But Michael's the timekeeper. He'll send me a text message. We're going over 30 minutes. But the time, you have to play around with the time of the meeting to make it agreeable for as many people as you can. And 7:30 is working for us.
Another question for anybody who wants to answer, and that is, how do you get, most of us know other clinicians, other people in healthcare, but how do you get patients to get involved in this? How do you get people who normally aren't at the table to show up?
The only patients that I know are people that are in the group that are actually patients of the community health center where I worked. We have not had the discussion within the group to see if there's anybody who could recommend a particular patient for us to reach out to. I'm not sure if Gabriella or Christy have actual patients, but I know in New Bedford we don't have a user of primary care.
But Pam, you do have lots of people from the faith community and the social service community,
Immigrants assistance.
all sorts of social organizations. So though they're not patients, they're hearing patients and they're hearing people and their experiences. And they're very important as well. And you've done an amazing job bringing them in.
It's true.
And ultimately, we all are patients. We all have our own healthcare needs. Maybe because many of us work in healthcare, we're connected in some way already, but oftentimes have had experiences ourselves or with family that highlight some of the crisis we're in. I know there have been some examples of people talking to patients about this, even in exam rooms, and inviting them to join. And I don't know if anyone has had success in other work groups getting some community members from lots of different roles outside of healthcare to join.
I might actually have something related to this. I'm not a health professional at all. I'm a student at VCU right now, but my professor mentioned this. I'm not majoring in anything health sciences related. It's philosophy and political science, but my professor mentioned this a number of times because it tangentially came up with subjects in class. So, in my opinion, I think reaching out to university professors would be a really good idea because they're inherently going to be talking to students like myself, a lot of whom can't afford health insurance themselves, or just majoring in things outside of health. Yeah.
That's great. And students are a great group to get activated and to do a lot of this organizing work.
Absolutely. And so for you, Gabrielle, that's your focus, right? Is sort of activating that student population. How have you done with, are all of the students that you interact with medical? How are you sort of looking at that array of, some might turn to the medical field, but not all?
Yeah, so it's interesting. I've done two different ways or a couple different ways of trying to reach the student population. So one from the volunteer offices from the hospitals and whoever they are affiliated with already. The other thing is I've reached out to a local college that one of the hospitals stated that a lot of their students come from. And I emailed their dean of health sciences, actually emailed everyone, the president, the dean of health science, anyone that was on the cabinet, the provost, whoever it was. And so the dean of health sciences responded and wanted to meet with me to discuss their students' involvement. And we're very eager to hear what we had to say. So we actually ended up meeting with the provost as well as the chief of staff and the dean of health sciences, like I said. So that it's very true, getting involved with the local colleges is how you can then, get some students that you wouldn't otherwise reach. The other way would be the community-based organization, not the community-based organization, sorry, the local politicians' offices. They have agreed to distribute, once we do start the program, distribute the basically who the contact person would be, etc., to the schools that they also serve within their district. So 3 ways: the volunteer office, me just figuring out what colleges are already affiliated with the 2 hospitals, and then also the local politicians' offices to dispense that information.
Well, that is incredible amounts of information. Everyone looks like they're ready to go, so we'll be all set for a while, right, Michael?
I think so. I don't know how to thank everybody enough for your work and thinking about this and working on it together. Um, this is the future. You know, while the folks in DC are fighting with each other, we have the opportunity to do this and do this together in and for our own communities, which is pretty spectacular. And you saw and heard from a number of people tonight who are doing it in real life, in real time, and that means you can do it too.
Well, we will see everyone on March 11th. We will have another one 2 weeks after that, where we will be diving further into some of these topics. So make sure to invite your friends to come, your patients, your colleagues, your local college students. We appreciate all of you. A special thanks to Sarah and Matt as our co-chairs and just all of the great work that's being done by the team here. Have a great night, everyone.